So why Habitus and why have we put on this session? Well, Habitus Collective started out in December 2014. We're a group of leaders, peers from the tech, research, health, community services, and the arts. Our first ever meeting was in a disused shop front in Western Canada, where, to my memory, not one chair matched. And we got together in a circle and we discussed how we could start doing some things differently. So what's important to us? Well, improving community and health services with better data, more community leadership and planning. We also want to kind of show and put lights on the strengths and the gaps in the sectors that we work in, particularly community and health. I think for a long time, those organizations that actually deliver the services often have a limited ability to track impact in the complex systems they're working in, and they're not given the resources of their support to share that impact. So why recovery colleges in particular, and what's Habitus's interest there? Well, Habitus led the largest evaluation yet of recovery colleges in Canada to this point. We've analysed the outcomes of over 4,000 students across 5 recovery colleges, and part of our mission is to mobilise those learnings and turn the knowledge into practice and action. We have offices in Canada and in the UK, which means we try our best to share ideas and strategies between organisations on each side of the Atlantic, and in Europe and in the US. We share information between organizations, communities, populations, and the whole idea is, can we accelerate the time it takes to turn great research and data into practice, evidence and impact? Whew. Okay, that was quite a mouthful. Before we do jump into introducing our panelists, I never like to assume knowledge and make sure that we're all starting from the same point. So I do want to answer quickly, what the heck are recovery colleges? So for those of you who don't know, recovery colleges offer educational courses that are about mental health and or addiction recovery. This is still a pretty new way of delivering mental health services. Courses are designed to increase student knowledge, skills, so that they can thrive. Leading recovery colleges will have peer support principles at their core. Some colleges are based in hospitals and only open to the patients that they serve. Some are in specific communities, like for people experiencing homelessness, and some are completely open to anyone and everyone from a geographic region. The impact that certain recovery colleges are driving for can change. It depends on which country they're located in, their geography, the funders that they have, the health authority or trust that they're part of. But much of the research, evaluation and monitoring to this point has focused on individual student recovery indicators. And so we're dead interested in, well, how do we kind of move forward and through that. The very last piece that I think is dead interesting, and I'm sure the reason why so many of you are here today, is that almost all reports, evaluations, pieces of research done for Recovery College are just filled with praise and support for the model. And they particularly mention the feeling of equity that they have and the fact that, that our folks have more control over their recovery journeys. They love being students and not being patients. Okay. So that is basically all the talking, hopefully, I'm going to do in the agenda, apart from asking some questions. So without further ado, I'd love to introduce you to our 3 panelists. Rather than me talking through their bios, I'm going to get them to introduce themselves. So I would love to start with Priscilla.
Thank you, Callum. Good morning or afternoon or evening, everyone, wherever you are joining us from in the world. Thank you so much for being here and being interested in this topic. And also, I just want to thank Callum for doing that important land acknowledgement at the beginning. You know, it's so important to keep having these conversations, because what continues to happen isn't it's not a history thing. It continues to show up today. So thank you so much for that important land acknowledgement. My name is Priscilla Cherry. My pronouns are she, her. My mother's side of the family immigrated from Trinidad and Tobago. the beautiful Caribbean islands and settled on the stolen land of Treaty 7 territory, Mohkinstsis, where I now call home, and was born and raised. Here she met my father, who is French Parisian Canadian, so I identify as a biracial Black woman. And I am one of 3 co-founders of The Color Factor. We're a nonprofit organization that is founded, governed by Black, Indigenous, and racialized women with expertise in wellness education, peer support, and social justice activism. So really our mission is just to disrupt, deconstruct, decolonize, and really reimagine traditional healing practices in the mental wellness space, but specifically as it relates to Black, Indigenous, and racialized communities. And yeah, my experience with mental health education is lived experience. You know, I have firsthand experience navigating my own mental health concerns, and really just navigating a mental health care system and services that weren't actually designed with me in mind as a biracial Black woman in the first place. So that's really why The Color Factor was born. I also have secondhand experience navigating conversations about mental health and wellness and substance use concerns that continue to affect my friends and my family to this day. So in all of that, recognizing these gaps in, and the shorthand, I guess, for Black, Indigenous, and racialized, because that's a little bit of a mouthful. So the shorthand for that is BIPOC. So I'll be using that moving forward. But recognizing these gaps in BIPOC communities when it comes to misrepresentation, underrepresentation, non-representation, coupled with the shame of having these conversations, you know, just the cultural shame. There's stigma already exists when we talk about mental health concerns, but there's even a further stigma in like our communities. So that's what led me to become a peer support worker and use my lived experience navigating these things, which is what led me to Recovery College. And our team at The Color Factor was part of co-developing and co-facilitating wellness courses for the very first Recovery College in Canada through the Canadian Mental Health Association Calgary chapter. And I just fell in love with the Recovery College model and peer support model as a whole because for my own healing that I found, like the holistic healing aspects. I love the people first, people-centered approach. You know, it's just a great tool for myself where I was at in my journey. And I believe can be such a great starting point, midpoint, wherever point for so many in recovery. And, you know, personally, my journey has evolved since being introduced to this model 6 years ago, 6 or 7 years ago. Wow, it's been some time. But I would say that the only thing really missing is, again, that anti-racist, racial trauma, BIPOC-informed lens. And I learned that I was actually the first racialized person to complete Canada's first ever peer school through CMHA. And while that may sound like, you know, an incredible accomplishment, it is very telling and like a very real truth and representation of the actual state of our country's diversity, equity, and inclusion practices, and, you know, that truth and reconciliation that the government talks about. So proud to say that, but then sadness, you know, immediately follows because I'm just reminded of how much further we have to go a little bit, but it's not impossible, you know, recovery focused, hope focused. So yeah,
Thank you so much, Priscilla.
Oh, thank you. Okay,
no
I'm gonna.
Worries. That was awesome.
I'm excited. Thanks, Callum.
Brilliant. I'm going to pass it on to Gayatri.
Thanks, Callum. Similar to Priscilla, sitting in Calgary, I just wanted to acknowledge the land and the territories of the people that I sit from. I'm originally from India and an immigrant settler here in Calgary, and just you know, recognizing the truth of colonialism and racism and how it shows up in different ways. It has been a sort of a hearty reminder for all of us to the work really the hard work lies ahead. So recognizing the Blackfoot Confederacy, the Treaty 7 land comprising of Siksika, Piikani, Kainai, Tsuut'ina nations, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wellesley Nation, as well as the home to the Métis Nation of Alberta, Region 3. I just want to give a quick acknowledgement that a lot of the work of Habitus currently is also with the city of Calgary, currently working on their anti-racism initiative. And so a lot of the work that we are now bridging is between mental health and racism. And so, just talking through Callum, some of the experiences that we hope to bring in this conversation today is not just the evaluation lens, speaking from the perspective of being a part of the team that also, took part in this evaluation. And I know my teammate Lisa Alford is here watching as well, so big shout out to her who led this work. But also to recognize that this work is evolving and we're learning to bring in a much more systemic and community focused lens as we take this work forward. So thank you for having me.
Thank you so much, Gayatri. And last but not least, Jeremy here in the UK too.
Hi there. So my name is Jeremy Coutinho, and I have managed the Recovery College at South West London, St George's, for just over 7 years now. And our claim to fame is that we were the first recovery college to open its doors in the UK back in 2010. As well as that, I also started up and set up Elephant in the Room, which is a training consultancy company. And the aim for that is, I think we can really make a big difference, or mental health will start to be viewed differently if we can get the private sector to change how they work. Once we can get them to understand, actually, this is about looking after your staff, improving their effectiveness, keeping them well, and improving their productivity. Actually, I think we can change things quickly. And I think there's a lot of talk about mental health and mental health awareness, but not real understanding. So we go in and we try to teach them about self-management, engagement of their staff to improve their recovery, and show them what impact it has. Sorry, but lastly, management for me is the biggest issue. Why are you going to talk about your mental health unless those managers, you're confident that they can deal with it properly? So we go in and train the managers. So that's the Recovery College. I think we lead the way. We've led the way for a long time, and for a number of reasons, largely around innovation. So we've started we're the only one I'm aware of that has our own internal peer training program. So peers are absolutely vital to us, and having an internal program, we're bringing people in, training them up, giving them the skills over a period of time, and giving them practice and training has been absolutely essential to us. We've set up quality assurance panels, so ensuring that we stay true to the model, and that we're looking at the quality of the courses we provide, the quality of the training we're providing, and constantly improving, giving our trainees the ability to develop what they do. And the proof in the pudding is our numbers. So we averaged, pre-pandemic, we were averaging 7 students, so that's average, in our sessions, and we run 250 sessions a term. So numbers are really extremely popular and successful. So why we stay faithful to the model, I think, as I mentioned before, and faithful to the Recovery College principles. So co-production peers are immensely important to us. What have I written there? I can't read my writing, I'm sorry. But alongside that is paid staff. So we pay our peers. I think that's absolutely crucial. Largely, they're actually on permanent contracts, just like our clinicians, but we also have agency. And I think I push that as much as I can when I talk to other recovery colleges. If you're talking about co-production and equality of roles, you need to be paying on the same contracts. And last but not least, coaching, not telling. So that's really key to our courses. That's how we change things. So why am I there? I love working in the Recovery College. How weird is that to say about a job? And the large part of the reasons is our peers. So when I met them, they're just amazing, so inspiring, absolutely passionate about what they do. And how often do you see that with staff members, members of a team being that passionate? So they keep me going, they keep our college going. I love doing that.
Thank you so much, Jeremy. I'm so excited. I call all three of the panelists friends because they're just fantastic people and bring very unique perspectives. So I've got a few of my own questions, but feel free, as I say, to post your questions as we go in the chat, and or as I say, if you'd like to post anonymously to Lisa. So I'm going to start off with you, Gayatri, if that's okay, because obviously we talked a bit about evaluation. So the first question would be, what approach did you take with the evaluation? Tell us a little bit about it. And what were the major impacts that you found, the benefits, the challenges? And I do want to say to Priscilla or Jeremy, if you've got anything to add, feel free to interrupt. More of a fireside chat. Go for it, Gayatri.
Yeah, thanks, Callum. I'd want to start with where we entered into the work with CMHA Calgary. So we were sort of initial partners, and I use the term partner very strategically here, because very early on at CMHA Calgary, they understood the value of evaluation, not as an add-on, but as a part of that developmental journey that an organization, especially one that is focused on innovation and change, needs to take to be able to try something, test it, change it, and then go again and try it again. And so our relationship with the organization over a couple of years has evolved right from starting to evaluate their peer school and then moving on to Recovery College across Alberta. There were several big asks for this particular project. Number one was the scaling. So they were taking a model and what we have called sort of a distributed network pathway. So they kind of were replicating the model across several sites. But the term replication is used very loosely here, because of course, recognizing that each site had its own context, had its own sort of processes. They had their own partnerships within each site. And plus, each site came with its own understanding of what this meant to their staff, to their clients, to their community, to their partners. So in a sense, there was this interest in understanding how is this model being scaled up. Just as a note here, quite often scaling of social programs is an area that isn't evaluated. So when we went into the literature of recovery colleges, we actually found very little to guide us in a way. So there was a lot of interest there to understand, okay, what are we scaling? What are those key features that really matter? So it doesn't matter you expand it to 10,000 people, 20 sites, but what needs to remain essential for it to be still called a recovery college? There was also interest in understanding sort of the summative evaluation and, especially focused on, are we efficacious? Are we impacting the right people? Are we reaching the communities that we need to reach? So really about service delivery, efficacy, and impact. And then there was a third piece, which was the more developmental piece, which was to understand how is this whole thing unraveling, or how are we actually unpacking this complex model and actually putting it in different sites. And there was a piece where we acted more as developmental partners, providing feedback, providing engagement. So there is the process piece, the summative piece, or the developmental evaluation piece, and then this model and scaling. So that's the short answer to a 3-year complicated, evaluation process. And then, if folks are interested, we can definitely talk sort of offline about some of the strategies we used. A few key things I wanted to note. One was that we consistently were using an iterative approach, which was flexible to the needs of different sites, especially this past year when COVID hit and they had to dramatically shift their programming online. They had to move to a hybrid model in some cases. So the ability of our evaluation team to essentially think through how do we shift our processes of evaluation, how do we measure differently, and how do we capture some of those intangibles that were occurring in these spaces. Number two, I want to focus on is the fact that a lot of this was uncharted territory from an evaluation perspective. While there was good evaluation around individual level impact measurement, what happens to an individual, like Priscilla was saying, there is such good, robust data around how individuals who go through a recovery college come out on the other side. Far less was known around what is happening to communities, what are happening to partners. Are there shifts in systems? Because we are making these claims about colleges, but the evidence is still fairly sparse. So that was a big part of the evaluation, to really say, we're going to take that 40,000 feet level kind of view of the college, not just looking at it from the user experience of the individual going through it, but communities and systems as well. So that was something that was also quite unique. And the third piece, I think, which we did was we took the idea of the colleges that was a lot of the literature has come from UK. And so, we were trying to shift and bring some of that using a principles focused lens and saying, okay, what makes this an Alberta model? What is it about this model that is unique? What are the key principles? What makes it sort of a made in Canada model? So some of that, foundational theoretical work also was undertaken in collaboration with CMHA. So that's a little bit about the approach. And Callum, stop me if I'm like going too fast, too slow.
If you can hit on the impact, I think that would be
right.
Awesome.
And so the main section here is the impacts, right? And we really talked about impacts at different levels, right? So at the student level impacts, there was a broad understanding that there was better social connections and belongings. And again, going back to this idea of these principles that underlay a lot of the work, we saw that better social connections and belonging, capacity to manage their own mental health and recovery, ability to apply those skills and informations to navigate the system better. My colleague Lisa here, who's on this call as well, did some incredible work around system navigation work and systems mapping with some of the clients in recovery colleges. We did notice improved mental wellness, but overall we also saw that the college was essentially a system disruptor. People were able to access services in an easy, timely manner. They were out of the wait list. It moved away from a diagnosis focused. And they were able to more effectively use the systems when they needed to use, which I think is an issue of better management of resources as well. So people were going to crisis care or going to hospitals when they really needed it. Overall, the model worked, and sort of people ask us, did it work? And yes, the short answer is that. And it worked to improve not only the lives of the individuals that went through the college itself, but we noticed shifts in partnerships and ways systems understood peers and the value of peers. And most importantly, they understood that wellness is not just clinical wellness. It's a more holistic wellness that can be actually measured and seen. So that was sort of the short version
on that point, Gayatri, and maybe this is a great point for Jeremy to come in. So you mentioned that there is proof that recovery colleges in Western Canada were system disruptors. And I suppose, Jeremy, I don't want to kind of release your age, but it's been more than a decade running your recovery college, is that right? And maybe just from kind of a delivery perspective, would you say that the Recovery College in Southwest London is changing those pathways to care at all, or has?
So yeah, there is an age issue, but it's only 7 years, so yeah. I wish I could say yes. It's in part yes and in part no. So we started, as I think you alluded to earlier, recovery colleges are funded differently. And we were funded by the trust, by the organisation that we run. So they found the money within current services. It wasn't separately commissioned. So we initially only offer services for secondary care clients. So that means people who have been referred by their general practitioner to specialist services, and then they're seen by they then pass a certain level, so they've got a high level of need, and they come into secondary services. So that's only who we're open to. So that's quite a high level of mental illness as well. Having said that, it's extremely successful there. So we've been, although we've been doing very well, I think the point I've made, I want to pick out here is that the difficulty has been with getting clinicians to understand that. And that's for a number of reasons. One, because they have targets coming out of their ears. So how they can focus on something new is just incredible, impossible. The other one is time. So they're given so many clients, so much work to do, so many targets. They don't have time to learn something new. And the last one was, I think they often saw it as a threat, the recovery college as a threat to what they were doing. So we tried to change this over time. By then seeing and actually working alongside them and recommending working alongside. So that's gone well, but that's taken a long time. It's a lot of hard work, a lot of toing and froing, meeting our peers. That has been absolutely transformational in terms of their understanding, and then getting their clients back and suddenly realizing, wow, look at the impact. They see the impact and they want more. So, the one point I forgot to mention was we had an incredibly high turnover of staff and clinicians. So I don't know how that is in Canada, but that's problematic for us because every 6 months you're going back to teams and a third of the team is new, so you're having to start again.
Is that seen in your peer support staff as well, or it's the clinicians that are turning over?
It's within the clinicians primarily. So yeah, no, we retain staff. Certainly at the college, we retain. And throughout the trust where there's peer support staff, they retain them as well. So the one point I'm saying about changing, sorry, Cam, but in terms of where we have been successful in changing the care pathway is going into primary care. So where our trust has opened primary care services, we've been part of that deal. And what we've done is we've developed recovery style courses there. They're more snapshots of our recovery. They're stepping stones. But we get people to come, and those teams have seen it, and they've brought them straight through onto our courses, and then they have immediate access to our full courses. That's worked a charm, and suddenly people are saying, actually, we need to be referring clients on at the beginning, not towards the end when we're discharging.
That's excellent. I am dead curious. Obviously, I have a strong advocacy sense for peer support. It has really helped me over the years, and I've been a big advocate for it. And obviously, working with Habitus, I've seen a little bit of our evaluation, and a lot of the learnings have talked about the need for peer support. So a really frank and hopefully not inappropriate question for you, Priscilla. If you wanted to scale recovery colleges, why wouldn't you just hire lots of mental health educators? In your opinion, as a peer supporter, having been in recovery college, why not just do that model? Is it not just simpler to deliver education sessions across recovery colleges across Canada and the UK? Why include a peer support worker? What's the value there?
Yeah, I mean, just to echo my co-panelists have shared, this is just from speaking from my own experience, like the recovery college or the recovery model gave me answers to lifelong questions that I had about myself that I did not find in traditional, like academia. So to answer your question, I mean, why not just hire them? I mean, just to be frank, it just hasn't worked. So for me personally, I just find so much connection in this model. And I feel like it really is, it's not a new model. It's very much like our DNA is rooted in storytelling. For me, peer support is storytelling. It's just us sharing our lived experiences through storytelling. So yeah, I don't know. For myself, it's not that the models that exist aren't working. Peer support is really just a complement to the system. It's not a replacement. We're not coming in like trying to burn down, existing things. It's just an addition and a complement to existing services.
Thanks for that, Priscilla. I can see there's a couple of questions coming in, but I'm going to get to the end of my list, and then I am definitely going to ask some of the questions that are coming through the chat. So I'm just going to pass it back to you, Jeremy, because obviously it has been quite a year. And Gayatri, you mentioned the change that a lot of recovery colleges kind of had to start off in Alberta. So maybe you can add, but I'd love to hear from you, Jeremy, kind of what would you tell people about putting the courses online? I think that's probably the primary thing around the pandemic, but for the next pandemic, here's hoping in 2200s. What do you reckon are kind of some of those learnings? What's worked best for your recovery college?
So sort of our experience of the pandemic actually most of the recovery colleges pretty much shut down as staff were diverted to clinical services. We managed to convince our trust not to divert us and to keep us in post, and we come up with a quick model. So we worked hard. We've got a huge home learning service that we set up that's essentially online. So we've got videos, we've got PowerPoint videos, PDF download, started with downloadable PDFs, and then phone line support. So the huge amount we put together in a short space. And we were always reticent to do this because the NHS is a bit of a monster, and it's like, well, online, that's a good way to go. We can, how much can we save? How many more people can you see? How many more? So that's what it was. It was bean counting. What has happened this time around, I think, and largely because clinicians have had to work with teams, they've had to do everything online, and they've been able to see it is not as effective as face-to-face. They know how much has been lost. So there is definitely a place, and we've created a big treasure chest of goodies that we can keep using that forever. We'll keep adapting, we will use them. But the good thing is that we managed to convince people that this is to go alongside. So we're probably looking at between 10 and 20% of our courses to be online, but really we want to promote the face-to-face. So, I mean, online, we found a new group of staff, a new group of students, a small one, but some who wouldn't have come in face-to-face. And actually, some of those are now keen to come face-to-face. So it's like another route in as well, which is excellent. But I guess we estimate that our courses online are only about 50% effective. So we can't cover as much content because you just can't get concentration levels for that long length of time. We've noticed our students are far quieter. There's a lot less discussion, a lot less sharing going on. A high percentage of our students use phones. So again, it's not a good experience. So
I'm dead interested, Gayatri. I know that one or two of the recovery colleges that you studied were rural in nature. And so it may be that those recovery colleges will continue to use virtual kind of supports. And I'm sure you can see some of the questions that I can see on the chat. It would be interesting to hear a wee bit if you've got bits that you're able to share.
Yeah, I have to be mindful that some of this is proprietary to the college. But it's really interesting, Jeremy, to hear what you've learned from your evaluation of these sessions. In Alberta, majority of the courses did shift online. And, I think what it did was, in some way, yes, the quality got impacted because they had to move sessions quite quickly into an online format, and some of those challenges around engagement remained. But surprisingly, what we found is that actually a student satisfaction with the content, still continued to be there. There was a greater sort of reach possible. In fact, people from across the world were now accessing college courses in Alberta. So that was, I think, a surprising finding for some. They didn't expect that uptake. And we found that actually people were finding the flexibility of the online model quite useful, especially if they had jobs and things like that, and they didn't have to go to a place. So rural communities, as Callum mentioned. However, we do find that people who are highly marginalized, who don't have internet, who don't have phones, who don't have computers. I think those are sort of that digital divide that we, are always talking about, right? So they are left out of this sort of transformational educational piece, who in some may argue are who need it the most. So I think there's that piece, but then the piece that really struck us was the level of people who continue to engage and who continue to come, and we could see that the rate of attendance and the rate of dropouts, so those were our measures of saying, okay, this is actually working. Yes, it's not catering to everybody that it was catering to before, but it's catering to a whole new section that we hadn't expected. So that's at a very high level that I can share a little bit.
Can I jump in there, Callum? I think from what I'm hearing, it sounds like the successful elements of the online course are that it's accessible and convenient, and I think we found that as well. I think what we were concerned with was the quality. So what were people actually getting out of it, and how much recovery, how much further were they in the recovery journey? So it filled a spot because there was nothing else out there, and people were extremely grateful for it. But it was about those same people were waiting until they could get face-to-face so that they could really have the impact. So I think it's probably worth digging a bit deeper to see what's the actual impact on recovery.
It'll definitely keep us busy for the next few years at least, digging into that impact. And I can see everyone's different experiences. So mindful of time, and there is no way we'll get to everyone's questions, but the really exciting thing about a session like this one is it's just the beginning. And I really hope that there was, I think, 55 of us on the call when we're at the high end. And so what I'm really hoping is that this is not our last chance to kind of collaborate. So with that, Lisa, I am going to ask you if you can direct the first question to Priscilla, because I've cut her question off in our list.
Hi. So the next question to Priscilla.
Yep.
So the question we have here is, how can recovery colleges better meet the needs of diverse folks?
Yeah, that's a really good question. First, I'd like to just kind of circle back to what Gayatri said about how this model, supports basically those that have been often othered or dismissed or kind of marginalized. So with this, I just think that we need to be more curious and ask more questions, like, when you're attending recovery colleges, or whether it's for the people that are in the ivory tower, the higher ups in those leadership positions, what does that look like? Like, is there actual representation of people in racialized communities? How do we employ racialized experts to maybe review the curriculums that are in recovery colleges? Because, are they inclusive of the narratives that Black, Brown, Indigenous, racialized people identify with? Or is it a little more Eurocentric, white-centered? I guess that's kind of what I would think about. It's really also what Jeremy said is about creating that access and that equity. Maybe it's even through scholarships, because a lot of our communities, the racialized communities, don't have access to attend. And I know, with recovery college, it's some of it is free. I'm not really sure of the spectrum of all of them, but just again, creating that access and the equity so that racialized people can see themselves as much as white and European people see themselves in the stories.
Thanks so much, Priscilla, and very great peppy answer. And I'm going to ask that from all of the panelists. So Lisa, can we get our next question?
Yeah, I have a question from an anonymous person here who asked, what is the differences between the UK and Canada rollout? And I think, Callum, you'd be a great person to bridge that answer.
I think we could talk about it for a long time, so I'll try my best to take my own advice about being peppy. I think often we love to kind of borrow a model internationally, and we really hope, whether we're in France, the Czech Republic, Australia, the UK, Canada, the US, and we'll say, oh, they're doing it great in another country, and we try to implant it. So obviously the UK went before Canada when it comes to recovery colleges. Having set up a recovery college, or being a part of the set up and recovery college in Canada, I would say that our model of delivery of healthcare systems is different. And what people don't, in my experience of Canada, and for those of you who are not in Canada, I would say that Canada split up into provinces and territories, and those provinces are very different province to province in how they deliver health. And I would say that the equivalent, if you're in the UK, is the way Scotland delivers healthcare in comparison to the way England delivers healthcare. They are definitely not similar. And you normally know that when you're in the smaller country, not the larger one. And I think the biggest difference is that many of the new and emerging recovery colleges in Canada are being run through non-profits. The very first recovery colleges, Stars Recovery College at St. Michael's Hospital and Ontario Shores, were initially supported and set up to help specific communities or patients of the hospital, but they opened up over time, where most of that initial kind of delivery in the UK, like Jeremy said, came from health trusts, but that's also changing in the UK now. In some ways, the thing that I think is most exciting about the two countries is we might becoming kind of more and more integrated over time, where our recovery colleges look more and more similar as we learn from each other's best practice.
Yeah, I can also add to what Callum was saying is that from our evaluation, from some of our work, what we noticed is the models that exist, it's a matter of scale around the continuum, and where the differences exist is how much does the recovery college integrate partnerships into their work. And partnerships become that sort of key marker in some way to understand where are they getting information from the partners? Are they just using them as sites to deliver courses? Do they contribute to the strategic and operational thinking of the recovery college? So if you were to think of the differences between the UK and even here, it's sort of a major element is those principles and structural strategic pieces, but also how much of partners shape the running of the college as well.
Thanks, Gayatri. I think we've got time for maybe 2 more questions, Lisa, if we're very spiffy.
Yeah, this question is from Inga. How are the peers educated? What would that look like in terms of, is it a yearly training, every week, every month? So I'll pass that over to probably Jeremy first, and then we can talk from the UK side, and then we can talk to Gayatri about the Canadian side.
Or Priscilla, I feel like the 3 of you should fight it out. Whoever's first, go. Go for it, Jeremy.
I'll be really brief. So our peer trainer program is a 9-month program. We take students through a curriculum of understanding group dynamics, what to look out for, how to support people, how facilitation, how co-facilitation works, co-production. And then we take them through 2 terms. So the first term, they're attending courses, attending sessions. They learn about the content beforehand, or watching. They have very specific reasons why they're there. They're a focus for each time they attend a session, and they write reflective practice notes on it. And then halfway through, they'll start to deliver part courses. In the second term, they'll deliver full courses. So there's a lot of initial training we provide. And then as a team, we have we've got a trainer development forum once a month. So it's learning really important for us, and we'll dedicate that time, half a day a month to it.
Great, thanks, Jeremy. Priscilla or Gayatri, would you like to speak to that? Go for it.
Yeah, I mean, my training was about 3 months long. So I took just like a weekend, like for the actual content and the theory. And then I went and did an actual, like I participated as a participant, as a student in one of the recovery college courses for about, I believe it was like 4 weeks, 8 weeks. So instead of that, it was almost like a kind of a shadowing position. And then from there, I just started to actually like co-design and co-develop and try my hat on as co-facilitating alongside like an education expert. So yeah, I feel like it's different a little bit. I feel like it's definitely evolved since I've taken it a few years ago, but yeah, that was my journey.
Thanks, Priscilla. Lisa, I think we've got probably time for one more, definitely, for sure.
Yeah, so last question, what is meant by community impact?
Go for it, Gayatri. I think that's yours. I saw you at the start line there.
Yeah, I can share, but I'm really curious also to hear from the UK of how they are seeing this impact. So we at at the CMHA Calgary and Alberta evaluation put some metrics down to talk about are they seeing shifts in terms of reduced usage of accessing mental health services, a better utilization of those services, reduction in stigma and discrimination in the community. We also looked at measures such as, employment, and are they getting engaged in their own, civic society. So these seemed like very large sort of outcomes that we started off with, and then we broke them down into really specific indicators to actually measure, have we seen those changes. There were challenges in getting some of the data, but even the initial brush that we saw, we started to see that there is some movement of shifting the needle. Also recognizing that community impacts are those mid-term impacts. So it takes about 3 or 4 years to actually start to see those. So for those who are starting their colleges and earlier in their journey, it's still those individual level impacts that we measured. For those who had been, say, 2 or 3 years in, that's when we started to actually see some of those changes. And then 5 years, we think, would be a perfect time to actually see, has there been major shifts in the community? So those were some of the high level pieces that we measured.
Great. So again, apologies. I know we got way more questions, but the great thing is you actually will be able to connect with one of our speakers in just a minute's time. So just before we get there, I'm going to invite the speakers, panelists, to kind of share a closing thought, a piece of wisdom, a sentence or two to kind of leave the rest of our guests with. So Jeremy, if I can pop you on the spot first, that would be magic.
Yeah, I guess my closing piece would be, and I hope it's come across, just how important the peers are to recovery colleges. They make the recovery colleges, and that's why I invest a lot of time and training, dedication towards them, because actually that's, so I mean, someone told me, I think we had it, Priscilla mentioned before, we've had students come through our clinical systems. They've been there for years. The first course I went to, a student sat there with his arms crossed and said, I've been here for 15 years and nothing's helped me. Why is this going to? For the second session, he was engaging, happy as a bunny. And this happens all the time. These are the things you hear all the time. And the impact that I see is that link between the peers and the role modeling that they provide. So.
Brilliant. Thank you. Gayatri.
I think for all of us on the evaluation team, the thing that stayed with us were those individual impact stories that that this matters, this work can make a difference, that peer stories are the heart of Recovery College. So there's one message that, I may be stealing Priscilla's thunder here, but I genuinely feel that a college without a strong peer support base and understanding and the value of peer support will just not have the same type of impact. So you can have all other fidelity features of a college, but without peer support, it will lack the soul that really makes the difference. I think for people who are coming there, for peer staff, and for the system in general. So that's sort of my closing remark.
I hope she hasn't stolen your thunder, Priscilla.
Not at all stolen. If anything, you're uplifting it, my point. So yeah, thank you, Gayatri. Yeah, I absolutely agree. Just to summarize, it's not about, you know, this either or approach. It's both and more. I recently actually listened to this podcast with Brene Brown, Unlocking Us, and she interviewed this activist called Tarana Burke, who's responsible for creating the Me Too movement. And they just summarized beautifully what I have personally been trying to articulate for some time now. They talk about co-creation, and they say how, you know, when it comes to co-creation, academic experience is needed to show the data, but lived experience always trumps academic experience because it tells the story of the data, right? And that's all it is. Like peer support, again, it's storytelling. So I feel like, you know, for all of us on this call, when we go out there in the world and we are a little change maker, be our little change maker selves, if we can maybe frame it in that way, it becomes less scary. You know, peer support is storytelling. It's